Good evening. My name is Dr. Kishore LT. I am the Director of Radiology Education and Training, Vijaya Diagnostic Center. Welcome to Vijaya Diagnostic Educational Webinars. We have been conducting this kind of clinico-radiologic education sessions for a couple of years now. And the purpose is that we interact with the clinician and we learn from each other so that eventually the patient is benefited. So today we have a very interesting topic. It is the evaluation of rapidly evolving dementia, for which we have three young dynamic faculty. I call them young because all of them are younger than me, but otherwise they are reasonably experienced also. So we have chosen this topic because conventionally dementia is a slowly progressive mental decline, but then there is a separate subgroup of patients where there is a rapid evolution, and often it is because of some secondary cause. And if we identify that cause and make a correct diagnosis and appropriate treatment well in time, the dementia can be stopped. Sometimes it can be reversed and it can be cured also. So that is the importance of imaging as well as clinical acumen, and we are going to discuss this thing. So first, we have Dr. Vemula Srikanth. He is an eminent neurophysician. He is MD from AIIMS and DM from PGI Chandigarh. He is associated with the Magna clinics and also associated with Apollo Hospital and previously Care Hospital. And he will be talking about the clinical aspects. Then we have Dr. Anuj Jain. He's a nuclear medicine expert and he has also done his FRCR, so he's a properly qualified radiologist as well. And he has been working with Vijaya for a long time and he has experience of working in UK also. Then we have a youngster, Dr. Ankit. He's a bright young radiologist. He has done his DMRD from Jain Hospital, Mumbai, then DMD from Yashoda. He has undergone a fellowship in Neuro, MSK, and research fellowships in Korea, South Korea, London, and the US. So all are very experienced people. So Dr. Srikanth, I would start with you. When the patient comes with the signs and symptoms of dementia, as a clinician, how do you approach them? And at what point you decide that he needs imaging? And when you send them for imaging, what are your expectations as a clinician? Srikanth, you are not able to hear you. I think there's some issue with Dr. Srikanth's audio. I think we'll sort it out in a minute.
Meanwhile, Dr. Srikanth joins. Ankit, maybe we can chat since we are online. I think this. So,
Yes.
Ankit, what should be the first modality of investigation, PET-CT or MRI in a case of dementia, and why?
So The indication would depend on the exact clinical history and the possible diagnosis. But in many cases, it would be MRI as the first imaging investigation.
Why do you say so? Why MRI? Why not PET CT?
There could be multiple reasons to this. First is MRI has an excellent soft tissue resolution, so it provides with anatomical as well as structural details. It can help exclude surgical causes as the first instance, which are easily treatable and are a different subset of etiologies presenting with dementia. Secondly, MRI is much more cost effective, easily available. Thirdly, it has impact not only in excluding surgical causes but guiding towards a definitive cause as well.
Fair enough. I think Dr. Srikanth, I think.
Yeah, I think Dr. Srikanth is back. So, yes, Srikanth, your clinical perspective, please.
Can you hear me, sir?
Yeah.
Can you hear
Yes.
me? Okay.
Yes.
So the reason you remember, sir, we discussed about dementias versus rapidly progressive dementias. So for me, anything that is treatable and anything which is urgent makes me focus sharper and, solve the problem for the patient. Of course, dementia is important and it is important for the overall management of the patient. But rapidly progressive dementias, because of the hope of being cured or treated, or urgently diagnosing it, it offers a much more important or interesting perspective as a clinician. So when I'm faced with a patient who has a rapidly progressive cognitive decline, along with other features like cortical features, it could be myoclonus, visual loss, memory loss, it could be ataxia, any of these features, I'm always worried if I'm going to miss a treatable cause. So in that regard, I try to initially narrow down the differentials to a certain few clinical conditions. I start out with treatable conditions. For example, let's say a patient came with seizures, progressive cognitive decline over a few weeks, and some focal features. Then I would think of a autoimmune encephalitis. Sometimes I may not get the serology right. I do an LP, I may not get it. So then I depend on radiology to give me further answers. Sometimes if they are seronegative autoimmune encephalitis, then I look to the radiologist to give me some clues on the MR or even PET CT. Although it's a non-treatable condition, CJD is often missed because of the various ways in which it presents. Myoclonus, visual loss, ataxia, cognitive dysfunction, akinetic mutism. There are myriad of ways in which it presents. Sometimes it mimics other treatable disorders. So I would like to know what features are there on MRI or PET CT or any other neuroimaging modalities which can give me a clue whether it is CJD or another treatable condition which is mimicking CJD. So, and of course, sometimes the metabolic features might have been there for some time. The same metabolic condition may worsen a patient's clinical or neurological condition. I would like to know whether a pre-existing metabolic condition has caused this rapidly progressive dementia or it's something else. All these clinical dilemmas sometimes need that the radiology provide the answers to me. So that way I get a scan done. Usually it's an MR, and then sometimes it's a PET CT. So these are the things I may need from radiologists such as you.
Right. So mostly it is MR, and then sometimes if MR is equivocal or if it not able to show anything abnormality, we'll go with PET CT and fusion imaging, PET MR and those things. So first I would request Dr. Ankit to talk about what is the role of MRI, and then we'll proceed further. Ankit, over to you.
Good evening, everyone. Thank you, Kishore sir, for the kind introduction, and thank you, Srikanth sir, for the valuable opening remarks. I am Ankit Balani, consultant radiologist from Vijay Diagnostic Center, and in coming 10 to 15 minutes, I would be talking about the radiological evaluation of rapidly progressive dementia. At the outset, here are my disclosures. There has been fair usage of copyright work for non-profit educational purposes, and these are my crediting sources. This is the era of artificial intelligence, and I thought, why not start with what does AI has to say in all this? So I prompted saying that imaging modality of choice for rapidly progressive dementia. AI said that it would depend on the clinical context and suspected underlying cause of the dementia, while in many cases, MRI of brain is often the imaging modality of choice, and the reasons that were attributed were a superior soft tissue resolution, multiplanar imaging capabilities, detection of structural abnormalities, vascular changes, and functional changes. I further prompted saying MRI versus PET for rapidly progressive dementia. And AI was strongly supportive for MRI as the initial imaging modality of choice. And if further information is needed about the brain function, metabolism, or specific biomarkers, a PET may be considered. With that prelude in mind, my objectives would be to briefly discuss the clinical perspectives, talk about the various imaging options available, and in detail talk about a structured approach for evaluation of patients with dementia using MRI as the modality. Dementia is a broad term used to describe a group of cognitive impairments and symptoms that interfere with the patient's daily life and functioning. The symptoms could be memory loss, impaired thinking, reasoning, language or communication problems, impaired judgment, impaired visual perception, personality and behavioral changes. Rapidly progressive dementia is a subset which has a relatively quick onset and rapid progression of both cognitive as well as functional decline in the individual. The etiology, as already discussed, is quite varied. It includes neurodegenerative disorders like corticobasal degeneration, frontotemporal dementia, dementia with Lewy bodies, Alzheimer's, progressive supranuclear palsy, autoimmune causes like Hashimoto's encephalopathy or sarcoid, antibody-mediated autoimmune encephalitis, infectious causes like prion disease like CJD and others, malignancy, toxic metabolic causes, and psychiatric causes. One place in neuroradiology wherein we heavily rely on a detailed clinical history is evaluation of patients with dementia. What we are interested in is knowing the exact clinical manifestation of the patient and details about the cognitive symptoms that the patient may have, that is, the attention problems, the memory problems, the language, the visual or constructional problems, apraxia, acalculia, or the personality change, that is, disinhibition or aggression. The physical symptoms like tremors, rigidity, hyperkinesia, falls, dysphagia, incontinence, or the eye signs. The time course, that is the onset, duration, and progression of the illness, and other relevant history, if at all there is a family history of dementia, the risk factors, or the toxic exposures. Goes without saying that our experience in clinical diagnosis of this entity is quite limited, and thus we would heavily rely on the neurologist working diagnosis of the differential after clinical examination of the patient. The workup includes cognitive testing by the neurologist. MRI is usually the initial imaging modality of the choice. All the guidelines, that is the UK, European, or US diagnostic guidelines, recommend the structural imaging, usually by MRI, as the first imaging modality. It not only helps in excluding the neurosurgical lesions, but also supports the diagnosis of specific neurodegenerative disorders. Then we move on to quantitative volumetric imaging, which helps identify and label anatomical structures. It quantifies volumes. It helps compare them to an age or gender matched normative database, and it provides volumetric tracking over the period of time. In cases of clinical ambiguity, we move on to PET using either FDG, amyloid, or tau. In the coming few minutes, the emphasis would be on the imaging approach of patients with rapidly progressive dementia. The first thing that we do is rule out a surgical pathology, that is, etiologies like subdural hemorrhage or an anterior cranial fossa meningioma or hydrocephalus, including normal pressure hydrocephalus, which are otherwise easily treatable, to be excluded first. Normal pressure hydrocephalus presents with a clinical triad of cognitive impairment, gait ataxia, and urinary incontinence, though all the patients may not have this triad. Imaging wise, we see dilatation of the ventricular system and Sylvian fissures, which is disproportionate to the generalized cisternal and sulcal prominence and associated with effacement of sulcal spaces at vertex. Next, we assess the signal changes. We do it using T2 and FLAIR images, which help us provide with white matter signal abnormalities. And we look at the susceptibility images for areas of blooming and diffusion imaging for any restriction of diffusion. Next, we assess the cerebral atrophy pattern. We do that using a 3D weighted T1 weighted images, or else thin section T1 weighted imaging in all the three planes. Next, if at all there is no abnormality seen for the age, we would recommend a reassessment after a suitable interval, or CSF, or imaging further with PET or SPECT as the case may warrant. So let's talk in details about the signal changes and the cerebral atrophy pattern, which are the mainstay of diagnosis of patients in dementia. This slide summarizes the signal changes patterns possible in evaluation of these patients. This may look a busy slide at the first go, but we'll slowly go through all of these entities and come up with a structured algorithm. So we'll be looking at presence of a flare or T2 hyperintensity. If there is none, it shows that it is unlikely to be vascular in origin. Supposing there is a flare or T2 signal abnormality, we would look at T2 star weighted images, that is the gradient or susceptibility images, the diffusion images, and further characteristics of the imaging abnormality. So let's start with flare hyperintensity with blooming on susceptibility images. In this elderly gentleman, we can see that there are multiple foci of blooming in bilateral cerebral parenchyma in peripheral distribution, with associated small area of CSF signal intensity with peripheral blooming in the left parasagittal frontal region, pointing towards a chronic gliosis with peripheral hemosiderin deposition. Along with white matter signal abnormalities, it is diagnostic of a probable cerebral amyloid angiopathy. The criteria was recently modified, that is the Boston Criteria 2.0 in 2022, which describes it into 4 tiers, that is definitive cerebral amyloid angiopathy and probable cerebral amyloid angiopathy with supporting pathology. Both these require histopathological confirmation, and thus I would not be talking about them in detail. The other 2, that is probable cerebral amyloid angiopathy, it does not require pathological confirmation. Any individual presenting who's elder than 50 years of age and presented with spontaneous intracerebral hemorrhage or a transient neurological deficit or a cognitive impairment with the following of 2 on MRI, that is any of the 2 strictly lobar hemorrhagic lesions, that is either an intracerebral hemorrhage, cerebral microbleeds, foci of superficial siderosis or convexity SAH, or 1 lobar hemorrhagic lesion along with a 1 white matter feature, that is severe perivascular space in centrum semioval or white matter hyperintensities in multi-spot pattern. This in addition with the absence of deep hemorrhagic lesions and other causes of hemorrhagic lesions are diagnostic of probable cerebral amyloid angiopathy. If only one of these features is available, in that case, we classify it as possible cerebral amyloid angiopathy. Again, pathological confirmation is not required. The next pattern, which is contrasting to the previous pattern seen on susceptibility images, is the areas of blooming on central distribution, that is in bilateral basal ganglia, thalami, brainstem, and cerebellum. This is diagnostic of an arterial vasculopathy and commonly seen in patients with hypertension, that is Binswanger disease or subcortical arterial leukoencephalopathy. Next pattern that we might see is presence of diffusion restriction in areas of specific involvement, that is the cortical involvement in insula, cingulate gyrus, or superior frontal gyrus, or areas like precuneus, cuneus, paracentral lobule, medial frontal gyri, occipital gyri, angular, supramarginal gyrus, superior parietal lobule, or inferior parietal gyrus. The deep gray matter may be involved, the most common areas being caudate and putamen, and in some cases the thalami. This is again diagnostic of Creutzfeldt-Jakob disease, which is a prion disease, has a grave prognosis and can be diagnosed using electroencephalogram and the CSF analysis. Next pattern that we see on flare images is confluent hyperintensities in the white matter or the deep gray matter in brainstem. When seen, it is usually indicative of subcortical hyperintensities of presumed vascular origin. This is usually graded using Fazekas scale, in which the score 0 means that there is none or a single punctate white matter hyperintense lesion. A score of 1 means multiple punctate lesions. 2, that is beginning of the confluency. And in 3, there are larger confluent lesions. As in this case, we can see there are larger confluent lesions in bilateral cerebral parenchyma and the deep gray nuclei, as well as the brainstem and cerebellum. Whenever they involve more than 1/4 of the white matter, it is usually called as a vascular cognitive impairment secondary to a small vessel ischemic disease. Next pattern that we see is not only the confluence in the bilateral periventricular white matter, but involvement of the anterior temporal poles or the external capsule region. This is a specific pattern usually seen in young individuals presenting with CADASIL, that is cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. These individuals may present with recurrent lacunar and subcortical white matter strokes. A similar pattern is involvement of the anterior temporal poles, that is the medial temporal lobes, along with the insular region. When seen bilateral and in an asymmetric pattern with no hemorrhage or restriction, it is usually indicative of an autoimmune encephalitis, which may have both neoplastic and non-neoplastic etiologies with it. A closed differential is usually an HSV encephalitis, which is usually asymmetric, or usually unilateral in nature. It usually spares the basal ganglia and may be associated with hemorrhage or restriction. And again, a very similar pattern of involvement of the medial temporal lobe with the claustrum bilaterally. This patient was a known case of Hashimoto's thyroiditis and was started on steroids, and a 3 months follow-up MRI showed complete resolution of the lesions. This is indicative of a steroid-responsive encephalopathy associated with autoimmune thyroiditis, also called as Hashimoto's encephalopathy. The MRI is normal in around 60% of the cases, while in rest, it may present with non-specific features of encephalitis, including the involvement of limbic system and the medial temporal lobe. Next pattern that we see is areas of restriction of diffusion in areas important for the cognition, that is bilateral medial thalami along with the paramedian midbrain. These are the strategic infarcts which may have distribution in either a large vessel territory, that is bilateral ACAs, parieto-temporal or temporo-occipital association areas, or a PCA territory in the dominant hemisphere, or watershed infarctions in the dominant hemisphere, that is the superior frontal and parietal regions, or a small vessel disease, that is multiple lacunar infarctions in frontal white matter, basal ganglia, or bilateral thalami. Just for the sake of completion of the ischemic etiologies, one quite related entity is transient global amnesia, in which the patient may have antegrade or partial retrograde amnesia for 24 hours without any cognitive or physical symptoms. This is secondary to an focal infarction in the hippocampus, that is CA1 region of the hippocampus, seen at the lateral edge of the hippocampal gyrus, closely abutting the temporal lobe. So to summarize the signal changes, we can see peripheral distribution of the blooming in cerebral amyloid angiopathy, while a central pattern in arterial vasculopathy, areas of restriction diffusion in Creutzfeldt-Jakob disease, the subcortical white matter hyperintensities of presumed vascular origin, and when they occupy more than 1/4 of the cerebral white matter, it is indicative of vascular cognitive impairment. Involvement of the anterior temporal poles and the external capsule region pointing towards CADASIL, involvement of the medial temporal lobe and the limbic system pointing towards either an autoimmune encephalopathy or etiologies like infectious or Hashimoto's encephalopathy, and involvement of strategic areas leading to strategic infarcts. Next, let's talk about the cerebral atrophy pattern. Again, looks like a busy slide, but we would go through that sequentially. If there is no atrophy, it usually indicates either a normal aging or a mild cognitive impairment or early dementia with Lewy bodies. However, if there is a diffuse generalized cerebral atrophy, that could be seen in etiologies such as Alzheimer's, vascular dementia, or dementia with Lewy bodies. We usually scale that using a global cortical atrophy scale, wherein GCS 0 means no atrophy, 1 means when there is just some opening up of the sulci, volume loss of the gyri pointing towards a score of 2, and a knife blade or a severely atrophic gyri pointing towards a score of 3. Then let's talk about focal areas of selective atrophy. If they are seen more in the frontal regions, as in this patient, which has bilateral symmetrical frontal areas of involvement with severe volume loss of the gyri and opening up of the sulci, With relatively preserved rest of the cerebral parenchyma, it's pointing towards a behavioral variant of frontotemporal dementia. This can also be seen in other FTLD histopathologies such as Pick's disease or corticobasal degeneration. A variant is usually seen with more asymmetric involvement of the left frontoinsular area of involvement. That is usually seen in progressive non-fluent aphasia. Next, we have a symmetric involvement of the temporal lobes, predominantly the anterior temporal pole, more towards the left side, involving the amygdala and the anterior hippocampus with selective loss of the anterior fusiform gyrus and relative preservation of the posterior structures. This may also be, this is seen in semantic variant of the frontotemporal dementia and sometimes may be seen in behavioral variant as well, wherein the right side usually predominates for the atrophy. Next, we have asymmetric atrophy of the parietal or occipital regions, usually seen in patients with posterior cortical atrophy, but may be seen in other differentials such as corticobasal degeneration or dementia with Lewy bodies. The parietal atrophy is usually scored using a Codem score, wherein the score 1 means mild widening of the posterior cingulate of the parieto-occipital sulci, a score 2 leads to substantial widening, and a grade 3 leads to an extreme widening of the sulci. Selective atrophy of the infratentorium, that is in the region of the midbrain, with loss of superior convexity of the midbrain, volume loss of the tegmentum of the midbrain, so that it becomes less in volume as compared to the pons, that is less than 1/8 of the volume, reduced anteroposterior dimension, and loss of the lateral convexity. All these signs pointing towards a progressive supranuclear palsy as the underlying etiology. May have signs such as hummingbird sign on the sagittal images or the Mickey Mouse appearance or the morning glory sign on the axial images. Next, what we see is a focal hippocampal atrophy pattern wherein the hippocampus and the medial temporal lobes are involved disproportionate to the rest of the cerebral parenchyma. Not only the hippocampus, but the entorhinal cortex and the perineal cortex may be involved. These patients are usually those suffering from Alzheimer's disease. We grade the medial temporal atrophy using an MTA score, wherein in 1, there is widening of the choroidal fissure. In 2, there is widening of the temporal horn as well. In 3, there is reduction of the hippocampal height. And in 4, there is substantial reduction of the hippocampal height. A new score recently introduced in 2018 is the entorhinal cortical atrophy score, wherein we look at the entorhinal and the perirhinal cortex. This is the area marked with this polygon. In score of 1, there is mild atrophy of the entorhinal cortex with widening of the collateral sulcus. In score 2, there is significant atrophy with separation of the entorhinal cortex from the tentorium cerebellum. That is called as the tentorium cleft sign. And in 3, there is significant separation of the entorhinal cortex from the underlying tentorium cerebellum. This is an alternative to the MTA score to help visually identify patients with Alzheimer's disease, with a score of 2 or greater having a sensitivity of 83% and a specificity of 98% for probable Alzheimer's disease rather than subjective cognitive decline. A variant that is usually presenting with an earlier age of onset, that is the presenile Alzheimer's disease, which typically involves the posterior cingulum or the precuneus with only mild hippocampal atrophy. So to summarize the various cerebral atrophy pattern, a generalized pattern commonly seen in Alzheimer's, dementia with Lewy bodies or vascular dementia, frontal predominant in the behavioral variant, and an asymmetric left frontoinsular involvement in the progressive non-fluent aphasia, temporal involvement with predominant involvement of the left side in the semantic variant of the frontotemporal dementia, and the right predominant being in the behavioral variant. The parietal or occipital areas involved in the posterior cortical atrophy, corticobasal syndrome, and the dementia with Lewy bodies. Midbrain involvement in progressive supranuclear palsy, focal hippocampal involvement in the Alzheimer's disease or the dementia with Lewy bodies. So to summarize, imaging is quite commonly used and is a challenging in evaluation of patients with suspected neurodegenerative conditions. That is because the patients, when they're presenting early in the disease course, the imaging findings are also quite subtle and equivocal. A detailed clinical history and a working diagnosis aids in image interpretation. The true role is not only to identify the diagnosis, but often to push towards or away from a particular diagnosis rather than making a firm, unwavering diagnosis. MRI is usually the initial imaging modality of choice, and the above mentioned structured diagnostic approach and algorithm may aid in diagnosis. I thank you all for your attention and will be happy to take the questions at the end of the webinar.
Thank you, Ankit, for beautiful depiction of role of MRI. I think now, before asking anything to Ankit, we'll go ahead first with Anuj. He's a nuclear medicine expert as well as radiologist. So he will be telling us what is the role of nuclear medicine and the fusion imaging in the rapidly progressive dementia. Anuj, over to you, please.
Thank you, sir. Are you able to see my screen, sir?
Yes.
Fine. So I start with thank you, Ankit, with a very descriptive and everything you have covered all about the dementia. So it always happens with me whenever I try to get into a debate with any radiology investigation. I feel like this, very tiny with so many things in radiology imaging which is already available. So same, I think Ankit has made me feel similar kind of thing. But anyway, let me just proceed with what I am given for. So this is a plot of dementia biomarkers against the clinical stage of the disease. So it shows that the plaque deposition in the brain starts quite early before the patient develops actual symptoms. Then nerve injury, then shrinkage and memory, and then activities get deteriorated. So one thing is here, why I'm showing this is now if you can see this green oval, this is the area when MRI is able to pick up the any findings, especially the atrophy. While the orange oval, this is the area where FDG PET picks up the abnormality. So theoretically, we definitely PET CT definitely has an advantage of MRI to pick up these early. If we go to the tau imaging and all, maybe we can pick up the disease much early when the patient is cognitively normal also. That's again a theoretical possibility. Now, with this background of theoretically superiority of FDG PET basis, I'll just show few cases which I have come across not infrequently. So my first case was 59-year-old male. He had some behavioral changes, memory disturbances since last 1 month with very rapid deterioration, clinical suspicion of autoimmune encephalitis. Obviously, first investigation was MRI. So these are T1 and FLAIR images. Didn't show much of abnormality except Fajica grade type 1 vascular changes. That's it. Not much of atrophy or so. These are T2 weighted images. Again, no much of atrophy, no much of signal changes or that sort of. This is diffusion weighted images. So although MRI was reported as normal, didn't report any abnormality, but this showed some kind of gyral restriction, especially in the right frontal lobe as well as head of caudate nucleus and few more areas. Although probably the reporting radiologist thought these are either artifactual or he just didn't pay much attention to, because it may not give quite confident if the general radiologists are not very used to see these kind of images, they may just pass it because their eyes is more acclimatized to see infarcts and frank restrictions, and so this happens not uncommonly. So the patient was referred for PET CT, and PET CT showed a significant hypometabolism in the similar area where we can see diffusion restriction. So it kind of confidently we can say that diffusion restriction is not artifactual, and obviously this gross abnormality. Finally, again, with the help of MRI, I would say I could give a diagnosis of CJD with the FDG PET images findings and a reviewing of the previous MRI. Yeah. So now coming to second case is a 55-year-old female. presented with neuropsychiatric symptoms since last 4 months, and then again she also had a rapid deterioration in symptoms. So again, MRI was the first investigation. It was performed, not much of atrophy. These are T2 and T1 images, not much of atrophy, not even much of vascular changes, absolutely normal. This again, diffusion and flare images, no signal abnormality, no atrophy, while the FDG PET images were grossly abnormal. It showed diffuse hypometabolism with hypermetabolic areas involving basal ganglia, perilentic cortices, brainstem, and cerebellar vermis, which is more or less diagnostic of autoimmune encephalitis. We ended up doing a whole body PET CT for the same patient, and we found a CA ovary, right ovarian mass with some retroperitoneal and even supraclavicular lymph nodes. So it was diagnosed as an autoimmune encephalitis, paraneoplastic in a case of CA ovary. So in my practice, it's not uncommon, even in the literature wise, autoimmune encephalitis could be normal on MRI in more than 50% of cases. Well, practically, if I see most of the autoimmune encephalitis, which I report because MRI being normal, so I see MRI shows, abnormality in only 20 to 30% of cases. To just further strengthen my hypothesis on this is a movie called Brain on Fire, released in 2016, and it's written by the person who suffered from autoencephalitis in 2009. She was 24-year-old that time when she started having symptoms, and they diagnosed as because of the non-specific symptoms that she was diagnosed as a substance abuse, then some psychiatric illnesses and all that, because in 2 times in the movie also it's shown that 2 times MRI was done for her and it was normal. And finally in 2009, since PET CT was not in that much of use and the utility and autoimmune encephalitis was not that established, she was diagnosed with the help of brain biopsy. And it is claimed in 2009 that she was some 250th case of autoimmune encephalitis. While now with the help of FDG PET CT, I think in every other month we diagnosed 1 or 2 cases of autoimmune encephalitis, which is so common and many cases where antibodies are also negative. MRI normal, antibodies negative, and brain is showing autoimmune encephalitis, and patient is getting treated with it. So in my opinion, in autoimmune encephalitis cases, if MRI is normal, that is a normal finding, because only in 20 to 30% cases it shows some abnormality. Now coming to some common neurodegenerative dementias. So starting with Alzheimer's, the FDG PET is normally shows temporoparietal hypometabolism, like in this case. And now to show the atrophy pattern, how it precedes the atrophy pattern, this hypometabolism, this is a parasagittal image, and you can see hypometabolism in posterior cingulate and precuneus region. While atrophy wise, we will see this region, it will be hardly any atrophy, or maybe you can label it 1. So almost no atrophy, and a significant, just to show the difference from the normal. This is a normal precuneus posterior cingulate gyrus, and you can appreciate the hypometabolism here. So the level of confidence when you report with PET in dementia goes much further, is significantly high as compared to MRI. As in the same case, you can see in all coronal CT images that there is a medial temporal atrophy, but still, when you do a PET and you can see that kind of hypometabolism, your diagnostic certainty is really high, because similar kind of medial temporal atrophy you can see even in FTD cases and even in vascular dementia and DLBDs. But this kind of posterior cingulate involvement and precuneus involvement differentiates it with all other kind of neurodegenerative dementia. Now, this is in case of DLBD, almost no atrophy, and you can see occipital hypometabolism with preserved posterior cingulate. Preserved posterior cingulate region. This is called cingulate island sign, and you can see the brain on CT images. There's almost no atrophy, and patient has presented with hallucinations. And so this is a case of no medial temporal atrophy and not much of vascular changes, as much as we can appreciate on CT. So this is how very confidently we can give a diagnosis of DLBD or any other neurodegenerative dementia. This is a case of Huntington's disease. You can see significantly reduced uptake in bilateral basal ganglia, there is some atrophy of hydrochondral nucleus, but I think in a first reading, almost I'm not sure, but I think 99% of radiologists will miss that chordate nucleus atrophy in this. While this is a normal FDG PET brain image, you can see normal basal ganglia uptake, which is almost equivalent to thalami and cortex, while in this case, it is significantly reduced. So again, I would say very confidently and very with a high degree of certainty, we can give a diagnosis. So although I agree that MR is a first line of investigation because of its inherent properties, which Ankit has already mentioned, but I feel in my routine practical practice, it suffers a great degree of inherent limitation of functional information, which is very much required for dementia imaging. Even sometimes we will see some changes, some signal changes or some atrophy, but still it becomes very difficult to give a conclusive diagnosis. Many times dementias are mixed dementia. You may see mesial temporal atrophy and you can call it Alzheimer's, but if the patient has some other component to it, say a frontal dementia pattern or some other dementia is also there, I think MR wise we cannot make that diagnosis of mixed pattern of dementias. And sometimes even the atrophy is too obvious that classical atrophies, as Ankit had shown, but still the non-familiarity among the general radiologist, many a times it misses, and that's how the patient comes for either remains misdiagnosed or comes for PET CT scan. So in conclusion, I would say MRI alone is not reliable in dementia imaging. FDG PET must be the integral part of dementia evaluation. So as Ankit showed multiple things which I was expecting him to say, so I can feel like now to start with a tiny thing, I can come and I can feel like Shashi Kumar Divar, that okay, MR has so many sequences, different scoring system, many signs and all that, but still the metabolism FDG PET, since it picks up the disease quite early and quite a few patterns we can see, I feel little confident over MRI many a times. But yeah, finally to say, I think PET MR would be the way to go. We need some information from MR as well as from PET also. So thank you with this. Thanks for your patience hearing.
Yeah, so that was a beautiful depiction of what the metabolic imaging can do, which may not be seen by the morphologic imaging, at least at the initial stages. So with these, I would again revert back to Dr. Srikanth and ask him whether what are your comments on this, and whether you have questions to Dr. Ankit or Dr. Anuj.
So first of all, fantastic presentations. I love your cartoons, Anuj. So and you had a very comprehensive presentation, and Ankit also elaborated in detail on other aspects of dementia also. That helps us, whether it is a rapid deterioration of a pre-existing dementia or a new one. It does help, what Ankit mentioned. So I think it is quite comprehensive. So when we ask PET CT problem is, everybody, it's difficult to arrange it for everybody, and what are the technical difficulties that you face while doing a PET CT, Anuj?
Technically, as of now, nothing much. Only thing, the diabetic patient sugar control should be good. That is one thing, and obviously that is for MR also, that we need patient cooperation. For 10 minutes he has to lie down still. That's the only thing. And if a patient is non-diabetic or the diabetic patient sugar is well under control, there is in today's era there is no technical issues that we can do on you ask in a 1 day, maximum 1 day. We need the 6-hour fasting. That's all. Another thing.
So autoimmune encephalitis, is it okay to go straight away for PET CT, skipping MR altogether, if you suspect autoimmune encephalitis?
So the thing is, means in certain cases, yes. If you have PET MR, nothing like it. Okay, and the thing is, CT also provides of a significant morphological information. Okay, if at all there are any vascular changes or some mass lesion or subdural hematoma, so we can rule out that on PET CT also. Okay, and metabolic information anyway we will get. Okay, so
I think,
if you have a strong
yeah, please go on, Anuj. I'm sorry I interrupted.
Yeah. So what I'm saying, if you have a strong suspicion of autoimmune encephalitis, PET CT, in my opinion, can be done straight away, as well as even in seronegative cases and all, there's quite a few cases where PET CT is only positive, and MR is even literature-wise it says 50% time you can miss, but whatever cases come to me, most of the time MRI is normal. I have hardly seen out of 10, one case MRI is showing some abnormality in autoimmune encephalitis.
So what is PET MR? I mean, together, can you elaborate?
Two types of PET MR. Earlier, when the machine was not there, now actually we have a PET MR machine in which there is no CT component. You put the patient, MRI is done, and PET scan is also done simultaneously. That is a real PET MR. Other thing is you do an MR on separate machine, PET CT on a separate machine, and fuse them. That is called co-registered. But that is not what I'm talking about. PET MR is like an equipment. Hopefully, we should get in Vijay in next 6 to 8 months.
That will solve a lot of the issues.
Right now, PET MR is available in Hyderabad city, and maybe in 6 months' time, hopefully, in Vijaya you may be having it. Yes,
that'll be great. It will solve a lot of the clinical problems for us.
Correct.
Yeah.
Right.
Thank you so much, Anuj.
I wanted to add one more point for Ankit. Ankit, there are many conditions like nutritional encephalopathy, toxic encephalopathy, metabolic encephalopathies also. They sometimes present the dementia of rapid onset. So there also, I think there will be a very important role of MRI.
Yes, sir. That is also one of the possible etiologies which may have significant imaging findings as well as rapid evolution of cognitive decline.
Yeah, right. Yes, Dr. Srikanth, anything else you want to add? Anything?
I think they've given quite a comprehensive presentation. So now I'm a little better to how to order the test and what to look for it. And of course, I'll depend on you, but it'll also give me an idea of how to interpret it myself. Before asking for the next PET CT or whatever test is appropriate. I think it's quite comprehensive.
Right. So that was a good interaction with the clinician and his perspective, and I think we have given our perspective, how much we can help them, and I think it will be eventually benefiting the patients in the treatment and their ultimate outcome. I just want to see whether there are any questions from the audience. I don't really see any questions from the audience. So I think we had a very fruitful discussion, and I would thank Dr. Srikanth for sparing his valuable time. I know you are a miserably busy person. And I am also thankful to Dr. Anuj and Ankit for doing a lot of hard work and making this presentation so nice, lucid, and informative. And now we'll close the session. Thanks, everybody.
Thank you, Dr. Kishore. Thanks for asking me to speak, and I learned a lot. Thank you so much.
Thank you.
Thank you.
Thank you.